sharing experiences, really important. Learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scan.
Both septal ablation and surgical treatment show good results. It's safe, comparable.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people. Nice to meet you all. Thank you for coming to our presentation today. My name is Emma O'Malley. I'm a registered genetic counsellor currently based in the Yorkshire Regional Genetics Service in Leeds, and this is my colleague Tin.
Okay, is my mic working? Yes, it is. So my name is Tin Wilson. I work at the Royal Brompton and Hayfield Hospital Trust. I'm also a registered genetic counsellor, and I'll be speaking in the second half. So I'm going to take a seat and pass back to Emma.
Emma, do you mind I face that tight a bit?
Of course I can, yeah. And if I do go quiet again, just somebody give me like an upward sign and I'll start to talk louder. So as I said, thank you for coming to our presentation. It's based on genetics and pregnancy planning. And let's get started. So here's a slide just to give you an idea of what you can expect to learn about today. We were conscious that the theme of this year's conference is the whole person approach, so we've tried to be mindful of that in terms of the things we plan to talk about today. So by the end of this session, hopefully you'll have some background knowledge about genetics and genetic counselling. We'll talk a little bit more specifically about the genetics of cardiomyopathies. We'll talk about the inheritance patterns that we can sometimes come across with the different conditions that we treat. And then I'll pass to Tin, who will talk about the importance of taking a nice detailed family history in clinic, about the current reproduction options and family planning. And then we'll illustrate some of these points by sharing some interesting case studies. Okay, so let's get started with genetic counselling and genetics. So for those of you in the room who have had a genetic counselling consultation, you might know that there can tend to be quite a long consultation. That's because there's lots of studies to discuss. So we'll start off nearly always by taking a nice detailed family history. It's a really important tool to us and it takes up a big part of our consultation for good reason. I won't go into too much more detail here because that's for Tin to go into later. When genetic testing is appropriate, and it isn't for all families, but where genetic testing is appropriate, we'll spend some time talking about the pros and cons of that test. Some people in the room might think that genetic testing is a no-brainer and how can there possibly be any cons to that? But there are lots of things to consider. So some of the pros of genetic testing are that we can find a causative gene change in some people, and that will allow for genetic testing and risk management in other relatives. It will enable things like prenatal testing for people that want to explore that option, potentially research options for people who have heard about Cure Heart today, where we need to have a causative variant identified. And I think sometimes psychologically, for my patients have told me, it just sometimes helped to know why this happened to me. But there are some other things to consider as well. So some of my patients come into my consultations worried about how it might feel to know that they carry this and might have passed it to their children, how it might feel in terms of the sorts of job opportunities that might not be applicable to them anymore, worries about things like life insurance. So there are things that we need to consider, and that's why a genetic counselling consultation before genetic testing is so important. Where genetic testing is appropriate, there are probably two main types of genetic testing that we'll carry out as a genetic counsellor. The first is a diagnostic genetic test, and that's the initial search for a causative gene change in a person with the condition, often the first person in the family diagnosed, and we call that person the proband. And that, as I said, is an extensive look through lots of different genes, and the aim, as I said, is to try and find a gene change that's causing that condition. In families where we do find a gene change, and that's not in all families, but where we do find a causative gene change, then that enables predictive testing, which is typically testing unaffected relatives to see if they've inherited that gene change as well. And depending on how closely related those relatives are, will depend on the chance that that person also has that gene change. Following this, we will offer some support to the patient, and as genetic counsellors, we're trained to give support to patients in lots of different ways, whether it be support through the testing process. Some patients might need more than one consultation to get to a point where they're ready to have their genetic test. Support after the result, support around sharing that result with family members, which is incredibly important. And then, because there are limitations in terms of the support that we can offer, particularly on a long-term basis, we might also do some signposting to other services, Cardiomyopathy UK being an excellent example of that. And then we'll talk about other things that feel important to that patient. And this can be a variety of things, but just one example of this is perhaps prenatal testing or family planning. But really, we can tailor our consultations to the things that are important to our patients. So in a few slides' time, I'm going to go into more detail about the actual genetics of cardiomyopathies, but let's start off with the basics. And apologies if some people in this room are really already quite comfortable with genes and DNA, but I always like to start at a point to make sure we're on the same page by the end of the conversation. So the way I explain this to my patients is if we think about the human body, it's made up of billions and billions of cells. And in almost all of those cells, we have the nucleus. And in the nucleus, we have an entire copy of our genome, which is essentially an entire copy of our DNA. Now, the DNA molecule is very, very long, and to be able to fit it into the nucleus, we need to sort of wind it up and condense it down into these structures called chromosomes. So our chromosomes are essentially storage structures for our DNA and our genes. And we have 23 pairs of chromosomes, and 22 pairs are typically identical in men and women, with the 23rd pair being the sex chromosomes. And in terms of what a gene is, it's just a section of that DNA that acts like an instruction or a recipe that the body reads, and then it creates a protein from that gene, and the protein will go off and do various jobs in the body. So it's just like a section of code really made up of chemical letters. And we have over 20,000 genes in the body, and they all do sort of slightly different jobs in the body. And most of them come in pairs, and we have a copy from mum and a matching copy of the gene from dad. And as I said, all of these genes have different roles. Some of them will work mainly independently, but most of them will work as part of a complex pathway or network. So obviously, as a clinical genetic member of staff or embedded within cardiology as Tin is, we're interested in gene changes. So a change in that gene that doesn't represent what the gene is meant to look like. And remembering that a gene is just a stretch of genetic code made up of chemical letters, a gene change can look like different things. So it can be a substitution where we have a change in one of the letters to a different letter. It can be an insertion of some genetic code. There can be some letters deleted, or we can have an inversion where a section of the code reads in reverse. Now, in clinical genetics or in genetic counselling, what we've historically been good at is understanding monogenic conditions or monogenic risk. And that essentially means identifying one change in one gene that is causing that one condition. And we're sort of fairly good at that now. But I think there's increasing evidence to suggest that some genetic conditions, including cardiomyopathies, are actually probably caused by polygenic risk. And this is a difficult sort of concept to explain, but it's essentially about having lots of different small genetic changes that individually probably wouldn't affect your risk of a condition too much, but added all together create this overall larger effect and this larger risk of developing a condition. So it's a challenging concept. It's more difficult to find these gene changes because, as I said, individually, they don't cause a lot of risk in a person, and they're harder to interpret. It's harder to interpret what this means for the patient and for their relatives, but there's lots and lots of research going on in this area, and I think in future it will be something that we use in a clinical setting. So up until now, I've kind of talked about gene changes like they're always a bad thing. But actually, anyone that was to undergo a diagnostic genetic test would be told they have lots of gene changes. And that's completely normal. It's really actually quite important that we're all genetically slightly different from each other. And so if we were to undergo a genetic test, any of us, the scientists will initially find lots of gene changes. And the job of the scientist is really to try and differentiate between those gene changes in terms of what is benign and what is what we call pathogenic, which means probably related to that condition. So the scientists will go through each of these gene changes they've found in a person and classify them from 1 to 5. A class 1 and class 2 variant, like benign or likely benign, means this is highly likely to be part of normal human variation. This change in this gene is not significant. It doesn't change the function of the gene, which is important, and it's probably just part of normal human variation. they won't even tell us about those types of gene changes. At the other end of the scale, we have likely pathogenic or pathogenic gene changes. And this is typically a gene change where it does affect the function of the gene. And we've got good to strong evidence that this is a thing that's causing the condition in that person. And as I said before, finding those types of gene changes can have lots of different uses. In the middle, we have this grey area, and we have what we call a class 3 variant of uncertain significance. And these are challenging gene changes to find for us and for patients. It means we've found something, but we don't know what it means. It's often a gene change that is quite uncommon in the general population. We may not have seen that very specific gene change in anyone else around the world. That makes it challenging because that means the scientists have got a lack of data and research to tell them how to interpret that gene change. So all we can do essentially in that setting is just press pause on the genetics. We found something, we don't know what it means. We're going to have to revisit it in a couple of years when the scientists have gathered more data in the background, and that would hopefully then allow them to reclassify it as benign or pathogenic. But at the moment, there's nothing we can do with this gene change because we don't know what the relevance of it is. We can't use it for predictive testing in relatives. We can't use it for things like prenatal testing. So, on to more specifically cardiomyopathy and the genetics of cardiomyopathy. So I'm sort of conscious that some of the information in these slides you'll be really familiar with because of your own current knowledge or things that have been said in other talks. So I'm going to try and focus more on the genetics. But you'll all know by now that a sort of normal heart is a heart that's got a nice, strong and flexible heart muscle that does a really good job of pumping the blood around the body. And so cardiomyopathy really is just a general term for the condition that's affecting the muscle of the heart. Some cardiomyopathies, as you'll be aware, can also affect the electrical system of the heart, and therefore it can also cause arrhythmias. And important to know that not all cardiomyopathies are genetic, so we know that there are some out there that have really well-established acquired causes, and I'll tell you about them more later. And there's 4 main types that I'll cover in a bit more detail today: HCM, RCM, DCM, and ACM. So starting with hypertrophic cardiomyopathy. So this is a condition that Tin and I will see quite commonly in our genetic counselling sessions, and it's a thickening of the heart muscle that I'm sure you're all aware of. And the way I describe this to my patients is that this thickening is called by myocardial disarray, which is where we have the cells of the heart muscle that's shown on the bottom right. And in the 2 little pictures there on the left-hand side, we can see the heart muscle cells nice and linear, nice and tightly packed, really well organised, makes for a really nice, strong heart muscle. On the right-hand side, we can see myocardial disarray, which is where these cells have gone a bit higgledy-piggledy. They're all over the place. They've got some gaps between. We can have some scar tissue building up in those gaps, which can lead to a thickening of the heart muscle. And this, of course, affects the heart's ability to pump blood around the body. We can sometimes offer genetic testing to look for the cause of HCM in people who are eligible, and that's an important point because not everyone's eligible for a genetic test. Eligibility is defined by something called the National Genetic Test Directory, so that governs the types of tests that we can carry out in the patients in the NHS and the reason, this sort of condition and the eligibility criteria. And people typically need to have had this condition diagnosed under the age of 60. We're not amazing at finding the underlying genetic cause of all the genetic conditions really, but particularly in the cardiomyopathies. And in HCM, I went to a conference earlier this week, and in their talk, they said that we're probably only finding a causative gene change in around 30 to 40% of patients. So that leaves quite a big chunk of patients who have the condition, but we can't pinpoint the exact cause of that. Like I said before, historically we've been good at finding these monogenic causes, but there's now increasing evidence to suggest that some people with HCM is being caused by a polygenic risk. So a collection of smaller gene changes that have been added together to increase that person's overall risk of developing that condition. When we do find a monogenic cause, we'll often find a change in genes called MYH7 and NYBPC3. It's often a dominantly inherited condition, and I'll tell you more about that later. But there's high variability. So we'll find lots of people where we have a couple of people in the same family with the same condition, the same gene change, but they'll be affected really differently. We don't quite understand why. It's probably due to some environmental factors, perhaps due to some other background genetic factors. But I always sort of start my consultations by telling people this is a really variable condition. Restrictive cardiomyopathy is something that I don't see commonly in my clinics. It probably only accounts for a small proportion of all cardiomyopathies. It's often diagnosed in childhood, and it relates to this stiffening of the heart muscle. So rather than the thickening, it's a stiffening of the heart muscle, but that still obviously affects the heart's ability to pump blood around the body, and it can also cause arrhythmias as well. Where we do have a genetic cause, we have a couple of genes where we are more likely to find a change, an example being TNNI3. But we know that it's not always genetic. In fact, probably a decent proportion of cases are not genetic and are caused by some other secondary underlying cause. So, DCM, again, probably one of the more common conditions, certainly that I deal with in my clinic. Tin might be the same. And it's almost the opposite of HCM, I suppose, in that we have this stretched and thin heart muscle wall. Makes it a bit baggy, it makes the left ventricle look a bit bigger, so some people would describe this as having an enlarged heart. And we know that this is not always genetic, so there's some really well-established non-genetic causes of this. And that might be that people have misused things like drug or alcohol, it might be that people have had some serious viral infections as a child, certain types of chemotherapy can cause a DCM picture, and also pregnancy can be a trigger for DCM as well. Again, there's a couple of genes there on the slide, there's examples of genes where we more commonly find changes, and a positive result when we carry out this test in about 25% of cases, and that probably does illustrate the fact that not all DCM is genetic. Again, it's usually dominant, and again, it's highly variable. So ACM, or as people might be more familiar with the condition, ARVC, is another cardiomyopathy that is also can display as an arrhythmia as well. It used to be called ARVC because we used to think it only affected the right ventricle, but now we know it can affect both ventricles, which is why we've moved away from ARVC and now call it ACM. And this is a bit different where it affects the glue that holds the cells together. And where we have some spaces between the cells, again, we can get scar and fatty deposits, which is quite a characteristic thing that can sometimes be seen on heart scans. And it is usually a genetic condition. I think we're probably all aligned that this is mostly a genetic condition. So we're a bit better at finding causative gene changes. And again, there's a couple of examples there of genes that we might often find to be changed in people with ACM. And again, it's mostly dominantly inherited. Just a quick mention that we're aware that there are some other sort of cardiomyopathies out there. I haven't gone into detail about these because they're either things that we don't deal with commonly, there might not be true cardiomyopathies, or they might not have a genetic basis, but just to show we are aware of other types. So inheritance patterns. So in a few slides back, I mentioned about dominant inheritance. I've gone into more detail on this slide about dominant inheritance, and I've got some examples of some other inheritance patterns as well. I've gone into more detail here because it's the type of inheritance pattern that we'll deal with more commonly as genetic counsellors. And to explain about dominant inheritance, we need to remember that every person that has a gene will often have two copies of that gene. So in the example on the right-hand side, we have a man with cardiomyopathy, and he's got two copies of a gene, and let's say it's the MYH7 gene. And he has one normal copy of that gene that's indicated by the grey bar, and he has an altered copy of that gene indicated by the orange bar. Every time that man has a child, he will either pass on his working copy of that gene or the altered copy. So it's 50-50 to each of his children. It doesn't matter that he's got a working copy of that gene because the altered copy has a dominant effect. So it's a dominantly inherited condition. And also his children, as I said, have a 50-50 chance of having this condition too if they inherit his altered copy of the gene. That doesn't mean that if he has 4 children, 2 of them will have it and 2 of them won't. It is like a toss of a coin every time he had a child. So we don't just deal with dominant conditions, we deal with some other inheritance patterns too. So just some brief information about these. So recessive conditions are, I suppose, in some ways the opposite of dominant. A person can only have the condition if they have 2 altered copies of a gene. So an altered copy from mum and dad. A person who only has 1 altered copy is a carrier of the condition. They are usually not affected themselves, but there is then, of course, a chance of having an affected child. And with recessive conditions, we see that a person who, when we have 2 people who are carriers, their risk of having an affected child is 1 in 4. And that child is affected again, like I said, because they've got an altered gene from mum and from dad. There's a 2 in 4 chance that the child will be a carrier of the condition but will otherwise be unaffected, and then 1 in 4 chance that the child will be completely unaffected and will not be a carrier. And then we have X-linked conditions. So the 2 previous examples that I talked about relate to a gene change that's found on the autosome. So an autosome is a chromosome that is there in men and women, biological men and biological women. An X-linked condition is named as so because it's a gene change that's happened on the X chromosome. And you might know that men have 1 X chromosome and a Y chromosome, and biological females have 2 X chromosomes. So where we have a change on the X chromosome, a man will usually be more severely affected by that because he doesn't have a backup copy of that gene on the other X chromosome. He only has 1 X chromosome. He only has 1 copy of that X-linked gene. And so if there's an alteration within that gene, he'll typically be more severely affected. A woman with the same gene change on the X chromosome is often said to be a carrier of the condition. She isn't always affected, but can have some mild symptoms of the condition. And it does affect people in terms of how they will present with the condition, but also the risk of passing that condition along. So in this example, we have a man who has an X-linked condition. For this man, every time he has a daughter, the daughter will be a carrier because he has daughters because he's passed on his X chromosome and he can't avoid passing on the X chromosome that has the gene change. His sons won't be affected because they are sons, because they haven't inherited his X chromosome, they've inherited his Y chromosome. If we have a female carrier of an X-linked condition, there's a 50-50 chance that each of her children will inherit that altered gene, but it will mean different things for whether she has a son or a daughter. And then just 2 other types of inheritance patterns we see. So some of you may have heard of this. On the left-hand side, we have a de novo pattern. So this is where we have an affected person, but we've done a test in both parents and they don't have that gene change. So that would suggest that this is a brand new occurrence in that person. And this does happen. So these are genetic conditions that run through families, but it always has to start, that gene change always has to start somewhere for the first time in a family. And so a de novo gene change is a brand new occurrence in that person, often happens very early on in conception, perhaps when that person is developing from a tiny embryo. So usually we wouldn't expect siblings to be affected by this condition because, as I said, it's a new occurrence in that person. So the only other people that are usually affected is that person's own children. However, there's a bit of a caveat to that. So it's really difficult for us to absolutely prove that something is de novo, and we have to be mindful that there could be germline mosaicism here. This is where we have 2 affected children, despite the fact that we've tested both parents and both parents didn't have the gene change. And the explanation for this, we think, is that either dad or mum has a couple or more affected sperm cells or egg cells. So mum and dad would still test negative on a genetic test because we're testing the genes that are present in their blood, but it might be that gene change is present in a couple of egg or sperm cells. So there's a theoretical chance that this might happen again. So whenever we have a condition that we think is de novo, at least in my service, I'm not sure if it's the same at the Brompton, we would offer to test siblings just in case there's germline mosaicism happening. And we think the chance of that is about 1% in families where it otherwise looks de novo. So I think that's the end of my slides. I'll pass to my colleague Tim now.
Right, now I was told there was a clicker. There is, because I like to walk sometimes. So thank you very much. It was fantastic. I'm sure you can all agree everyone has a pretty good basis of cardiomyopathy now. So I'm going to take you a little step further into the genetic counselling aspect. So we'll start with the importance of family history. And as Emma said, if you've had experience in genetic counselling service, you will have been quizzed about your family at the beginning. And often they think, oh gosh, I really should have spoken to my wife about this, because they don't even know the date of birth of their own children. But that's more just because they're on the spot and they haven't had time to gather that information, and that's totally okay. But I'm going to show you now that whatever information we get is helpful, but the more we get, the better. So, clicker. There we go. Right, so I've got 2 slides on this. There's a few key points to taking a family history. The reason why is to identify inherited conditions. So we'll ask about you, your children, your parents and your grandparents and siblings, because we're trying to find out how is this inherited. And Emma's given us a lovely introduction to inherited patterns. Are we thinking this is dominant? Is this something recessive? Could this be something X-linked? What's going on here? So we're kind of asked to see, where does the disease run in families? The thing about that also is we can tailor the risk. So a lot of our patients come through, they don't even worry about themselves with the diagnosis. They're like, tell me about my children. How are my children going to be affected by this? And the only way that we can do that is to understand how they've got the condition. That's the important part. So in doing that, we can also determine which test is the right test. Having a genetic test is only the best way to go about diagnosing these conditions sometimes, if you get the right test. There's no point in doing a test for the wrong thing. So by understanding the family history, we can then offer the right test so that we are looking at the right genes. And as Emma showed, there's lots of different genes for lots of different conditions. As I said, this helps us to understand complex conditions, but it also helps us get to know patients. So what are patients dealing with at the time of their diagnosis? You know, do we have any ethical concerns about the family dynamic, socioeconomic problems? Some of our patients are struggling not only with their heart condition, but housing problems, other health conditions. Sometimes they've got a child that has special needs. There's a lot else that goes on with these families, and we have to, in order to do the whole person approach, we have to understand what's going on with these patients behind the scenes and not just for the 45 minutes that we have them in the consultation. So in some of these families as well, there are personal problems, so psychosocial considerations. Some people don't speak to their father, some people don't speak to their mum, they're not in touch with their parents anymore. And so by getting to know them through their family history, we can then help them. How are you going to share this information once you've got a genetic test result with the family that you don't speak to or haven't spoken to in 15, 20 years? That can be a little bit of a stepping stone, but that's why we get to know you and we can help you do that. One thing I wanted to mention was that when we see someone in our clinics, as Emma said, we do diagnostic testing. So someone already has a clinical diagnosis, but we're looking for the genetic diagnosis. And what helps by asking about family history, getting children's names, dates of birth, brothers and sisters' names, dates of birth, we can give letters so that they can give those to their family members. They can be referred for a cardiac screen. And so we're catching cardiomyopathy early, even before someone has symptoms, because you can have changes on your heart that we can only detect with an MRI, and we have to do that in order to start treatment. So if we can catch those things early by getting everyone screened, we can detect that and prevent any further deterioration of the heart muscle. So as I say, it's not only about you, it's about the whole family. And just continuing, so 3 generational family trees is what we as genetic counselors want as a bare minimum. So if, take me for example, they would ask me about my children, myself, my siblings, my parents and grandparents, so 3 generations above. And if I've had children, that's what they want to know as well. So yes, we might ask about your great-grandfather that, you know, may have was in the war and going on. We want to know what happened. As I said, it gives us information about all the people in the family and where the disease runs. Identifying who needs screening and contacting, that's what I meant with those family information letters. And then genetic counselors, when we train, you may not be aware of this, but we train in all spheres. We talk about cancer, we talk about general conditions, chromosomal, cardiac, metabolic conditions, all of these things. So when I'm sitting talking to my patients, yes, I'm interested in the cardiomyopathy or the channelopathy, so long QT and Brugada, but also I'm looking for anything else that I can do for you from your family history. So if someone mentions to me, oh yes, my mum had a breast cancer, I'm going to ask you, what age, what type? Have you been offered screening? Is there anyone else in the family? Because we are trained to look at everything about that family history. So you might think it's a bit odd, why is she asking about my great-grandmother? That's exactly why. So help us to help you. Again, we also need to advocate for you in meetings. So for some patients, as Emma said, there are eligibility criteria to have a genetic test. And some patients, you can tell they've got a really strong family history. And so we might go into meetings and say, I've spoken with this patient. I know what's important to them. This is why they don't want the test, or this is why they do want the test. So we are your representative when we go back and are sitting in a room full of doctors. So we want to get to know you because we want to advocate for you. And then, yeah, as I say, the more we know, the better we can advise you. And as I said, that includes cancer risk assessments. So I'm sure a lot of you want to know all about this today. I'm just going to caveat that some of these slides or words or terms may be triggering. So if you feel like you need to leave, I will not take any offense, I understand. But please, if you have any questions, write them on a piece of paper and we can ask them at the end. So, a list of reproductive options. Now, this is for individuals whereby you have a genetic diagnosis. So yes, you've got a clinical diagnosis, but you have to have a genetic diagnosis. In a situation where there is a pregnancy or you're planning, family planning, there's a few things. You can do nothing. First and foremost, you do nothing. You don't do anything. You tell us and you carry on with your pregnancy. There's also non-invasive prenatal diagnosis and invasive prenatal diagnosis. So I'll go through these and I'll talk to you about the differences. Then pre-implantation genetic testing, you may have heard of that, PGT. So what some people call special IVF. It's IVF with an extra step. Egg and sperm donation and adoption. It's really important to reiterate here, and another privilege that we have as genetic counsellors, that any decision that you make is the right one because it's yours. Whatever choice you decide to do in terms of family planning, it's your choice. We are just there to give you the information and to guide you through that, support you through your choices, and also to make sure that you're making an informed choice. So do nothing. You find out you're pregnant, excellent. You let us know, fantastic, wonderful. We might offer you the opportunity to talk about your options in a pregnancy. That's fine, you can have that appointment or not, it's not a problem. We may want to arrange additional scans for you or for the baby. So if it's the female who's carrying the pregnancy, that she has the condition, then we might want to look after her heart as well as babies. If it comes from a male partner, we're not so worried about mum's heart, but we are still worried about baby's heart. So we might want to check the baby through pregnancy. In addition, for some people, their birth plan is really important. They want to have a home birth or a water birth, or they want to be in a certain hospital because they know that obstetric team. So we might talk you through that and say, okay, what's going to be risk for you? How can we avoid that risk? Or how can we help you have your home birth and make sure that you've got, people on standby, you've got a hospital nearby, you can get to where you want so that you can still have the birth plan that you want, but you're doing it safely. And then with genetic testing, we can offer genetic testing after birth. So some people may have heard of cord blood testing. We can arrange cord blood testing. It's a little bit stressful because, having a child is a bit stressful at the delivery. So it mightn't always be a chance to get a cord blood sample, but we can certainly see you very soon after that to do a test for baby after birth. Okay, non-invasive prenatal diagnosis. So when cells break naturally, that forms cell-free DNA. When a woman is pregnant, the baby also has these little cell breakages, and that's called fetal cell-free DNA. So when a lady is pregnant, when she gets to about 9 weeks of pregnancy, we can take a regular blood sample from mum and we can do a genetic test. Now, this only works if it's the male partner that carries the condition, because ordinarily we would test mum and she would be negative. The only way that mum would be positive is if it's coming from baby. Okay. Now, some people might want to do this because it's non-invasive, there's no risk to the pregnancy, but they want to prep and plan for a baby that might have a genetic condition, and that's absolutely fine. Again, that comes into thinking about someone's birth plan. We might say it might be better just to have a baby in hospital as opposed to having a baby at home, but doing an NIPD test would be helpful because we'll know if the baby's going to be at risk of anything or not. At this stage, if the baby comes back to be affected, then we can end the pregnancy. And that is something that we can also talk to about patients in terms of how that happens and the different options around that. And then invasive prenatal diagnosis. So the reason between non-invasive and invasive is invasive carries a 0.5 to 1% miscarriage risk. That can be a little different based on which hospital you go to and the obstetric team that you're with, but that's the numbers that we quote. So there are two ways that this can happen. So a CVS or chorionic villus sampling or an amniocentesis. This is all done through ultrasound guidance. So there's an image over there. Effectively, it's the same, but what we're taking, the tissue that we take is different. So with chorionic villus sampling, we take placental tissue. Amniocentesis, we take amniotic fluid. So a CVS can happen earlier. The earliest that can happen is 11 plus 3 weeks. Often they'll make you wait until 12, just so that it's just a little bit better for the timing of the baby. But an amnio can be between 15 and 20 weeks. Now you may ask, why is there a gap between 14 and 15 weeks? And that's because at that stage, the baby is moving. So they don't offer any testing at that time. They might ask you just to wait another week so that you can have your amnio. And again, at this stage, an affected pregnancy could be terminated if you want to. Now, this is where we talk about personal choice. because some patients don't want to take that 0.5 to 1% risk of a miscarriage. Again, that's absolutely fine. For some patients, they're willing to take the risk because for them, knowing what's going on with their baby is better than not knowing. So again, that's absolutely fine. And we can make arrangements for the baby after birth based on that genetic test result. So PGT, or what people often refer to as IVF. So IVF is where sperm cells are taken from the man, egg cells are taken from the woman, they are fertilized in vitro, which means in a test tube, and then you create embryos, and embryos are implanted into the female, and a pregnancy hopefully develops. That's IVF. PGT is that, but with an extra step. When they create those little embryos, they get to the stage called a blastocyst, and a blastocyst is where they can then take one little cell from that blastocyst, they can do the genetic test, and then they will know which embryos are affected and which embryos are healthy. At that point, they will only implant healthy embryos into the female in the hopes of developing a pregnancy, and they will not implant the affected embryos. So the whole process can take between 6 and 18 months. It is quite a lengthy process. It's a lot for the females to go through. So again, that's information that we will give you so you are making an informed choice. The 6 to 18 months is very much dependent on which service you're at. So some services move a little bit quicker than others. And so again, we talk to you, understand what your motivations are, understand your timing concerns, because some patients want to go through this at the age of 39. That's fine. But then we'll maybe signpost you to a center that moves a little bit quicker than someone who's 25 and who's got a lot of fertility years ahead of them. In order to be eligible for PGT, there are some eligibility criteria. Of one, from a genetic perspective, that condition has to pose more than a 10% risk to the child. So for de novo or germline mosaic conditions, it's unlikely that you will be offered PGT, but certainly for any cardiomyopathy that is a dominant condition where there is a 50% risk to the child, that you will be eligible for that. Obviously considering the other eligibility criteria. So just to run some more for you, so the woman has to be under the age of 40, her BMI has to be between 19 and 30, okay? The couple ideally need to have lived at the same address for a year, don't have to necessarily be married, but if we as a service are going to help you have a healthy baby, we need to ensure that welfare of the child is taken into account, and so we want to make sure that that child comes into a safe and stable home environment. You can't be smokers nor vapors, and if you are a smoker, then you need to have stopped for at least 3 months in order to start treatment, okay? If you are out with those criteria, it's not the end of the road. It just means you are no longer able to have NHS-funded PGT, but you can self-fund or you can go a private route. So there are still options for you. Talk to us, we'll tell you. Testing in pregnancy, so if you are lucky enough to the little pregnancy develops, we don't often offer testing in pregnancy because then we are adding that risk again to a pregnancy that we've actually just tried to avoid. So not always indicated. Okay, then egg and sperm donation and adoption. These are very personal choices, and there are lots of centers far better versed in explaining these concepts, but there are options and we can signpost you to these. So very much as a personal choice. If you don't want to pass it on and you want to just not go through PGT and all that faff, or you don't want to test in a pregnancy, that's fine. We can help you then signpost you, as I say, to those centers. If a child is conceived using a donor, they will not need a genetic test, okay? And thank you, Steph. Yeah, you won't need those tests, and we don't need to do screening after birth. Sorry, I've got 5 minutes left, so I was like, oh. Okay, so some case studies. Again, this may sound similar to your condition. These are all randomly made up, but just to give you some examples. So we meet Jenny. Jenny is a 30-year-old female patient, and she's in a stable opposite-sex relationship. So she's been diagnosed with ARVC, or as Emma so kindly told us, now termed ACM, following a cardiac arrest. So she's had a genetic test with us. She's spoken to a genetic counsellor, and we found a pathogenic, or now you know, a class 5 PKP2 genetic variant. So what this means is that any offspring from her are at 50% risk, okay? And as I've just said there, incomplete penetrance and variable expressivity, this is what Emma alluded to in terms of all these conditions are variable. They express themselves differently, okay? And some of these conditions are not fully penetrant, so that you don't always experience the full breadth of the condition, okay? So what is the risk of a future child developing ARVC? it's less than but up to 50%. Okay. What reproductive options are available to Jenny? Natural conception, so that you fall pregnant naturally and they do nothing, all right. Invasive prenatal testing, PGT, or she can use an egg or embryo and adopt or foster some children, okay? So she cannot have NIPD, the non-invasive option, because she's female, she carries it. So any genetic test for the baby will come up positive. Practical and ethical considerations are there. So we need to think about what would be safe for Jenny. Can she manage a pregnancy with her heart condition, okay? And also understanding what are Jenny and her partner's views around pregnancy. What are their religious beliefs? What's their socioeconomic status? How can we help them have a baby safely, as well as looking after Jenny at the same time? Number 2, so this is Neil. He's a male patient in a stable opposite-sex relationship, and he's 45. He's been diagnosed with hypertrophic cardiomyopathy, and he's undergone heart transplant, and a pathogenic FHL1 mutation has been found. So this is on the X chromosome, so this is an X-linked condition. So I don't know if you remember when Emma told you, if a male carries an X-linked condition, he only has one X, so that is going to pass down to all of his daughters, okay? Because his sons get the Y chromosome from him. So what is the risk of a future son developing HCM? Slim to none. Population risk, all right? We can never say absolutely nothing because people in the general population can develop these conditions, but we've removed that familial risk. The familial risk is not there anymore. What is the risk of a future daughter developing HCM? Now remember, daughters or females have 2 X chromosomes. So one of hers from dad won't be working as well as the other one, which is a backup copy. So we say it's a little bit more than population risk, but we can't exactly say. We can't say, oh, there's a 39.2% chance that you'll develop HCM by the age of 60. It doesn't work that way, but she'll probably have screening for a majority of her adult years. And what practical and ethical considerations are there? So this is more of a psychosocial or a psychological discussion, because how does Neil feel about having, his daughters potentially having a risk and not his sons? How does he feel about actually having daughters? He will understand that his daughters are at slightly above risk of the population of developing HCM, so he might want to take that into consideration, and that's why he talks to us, and if he needs further input, then we signpost to other psychological services. And then we've got Simon. So he's 22, he's currently single, and he's been diagnosed with long QT syndrome. So this is not a cardiomyopathy, but it's just something else to promote chat about a VUS. So as Emma mentioned, this variant of uncertain significance is where it's a genetic change that is slap bang in between of benign, where we are confident it doesn't cause disease and it just makes you you, or we are confident this does cause disease. So he's in that middle ground. In that situation, we cannot offer testing in a pregnancy. He cannot go through to PGT. So in terms of family planning, he just needs to understand that there is a risk to his children, but we can't really quantify it other than it's probably up to 50%. We don't say 50%, but up to 50%. So what is the risk of a future child developing long QT? As I said, likely to be coming up to that 50%. So the child would need screening, okay? What reproductive options are currently available to Simon? So natural conception, all right, or using a donor sperm, because that's something that you can do even if you have a VUS, or adoption or fostering. So as Simon is currently single, it may be a few years yet, so hopefully he can come back to us in a few years, and we say this to all our patients with a VUS, come back to us. Let's see if there's more information. Let's see if anyone else in the family has developed the condition that we can offer them testing for and see if that variant follows the disease in the family. Obviously, we don't want people to develop the condition, but if they do, maybe it can help the overall picture of that family. So before I say thank you, I just want to share a personal thank you to everyone, and I'm absolutely honored to speak at Cardiomyopathy UK today. I have a personal family history of cardiac conditions, and it's just an absolute delight to give back to patients and colleagues. So thank you very much.
Thanks very much to Tin and Emma. That was a lot of information.
Sorry.
But all of it very useful. Thank you. Now, do we have any questions? We've got about 15 minutes. Otherwise, we can just talk. Okay. Are you happy to take questions, yeah?
Absolutely.
Yeah. Roberta.
Hi. I was part of the Genome Project and nothing came back for me. I've got restrictive cardiomyopathy.
The 100K?
Yeah. Do they retest that, or do you know what happens? And has anything changed majorly with RCM? Because sort of I've always been told nothing's really happening with RCM. But I've got a daughter, so I'm very interested in that.
Okay. So I'll answer, and please feel free to if I miss anything. So I think with the 100K,
What is that?
So the 100,000 Genome Project was where they took patients who had conditions that couldn't be genetically diagnosed, and so they put them into the 100K. So it's 100,000 people in this project, so 100,000 genomes, which is our whole genetic code, to see if they could find a genetic cause. So when they do that, they sequence your whole genome, but they kind of lift flaps to look at the cardiac genes. They don't look at anything else, but they look at the cardiac genes. So you would have been referred for a cardiomyopathy purpose and to see if they could find anything. I would certainly say if they didn't find anything with 100K, it is obviously quite thorough. However, genetic testing does move forward. So if it's been over 5 years, definitely get back in touch with your genetics, and I hope your daughter's having screening. Sorry? Is your daughter having screening? Fantastic. That would be one of my questions. But get back in touch. Genetics is changing all the time. So that would be my answer to you. Do you have anything to add?
I think I would just add that that applies to any type of negative genetic test. So you will never find a genetic counsellor saying, this is definitely not genetic. We're always limited by the technology at that point. So whether it's a thorough test like the 100K project or a panel test that we deal with as part of the NHS, we're only looking at the genes that we understand at that time. And I think 10 years ago, taking HCM as an example, 10 years ago, we could only test for 4 genes that we knew were related to HCM. Now we're testing for 22, 23 genes. Who knows, in 10 years' time, you might know of 40 different genes. So it's never a definite answer. It's never not genetic. We can reduce the chance that it's genetic through the testing, but we'll always caveat it by saying there could be further testing in future. Come back to us in 10 years' time and we'll look at the testing that's available then.
Thank you. How do we access your services?
Give us a call. No. I work at the Royal Brompton and Hayfield Hospital. So I'm currently the only genetic counsellor. So if you just ask for genetics, you should be able to find me. But asking your GP to refer you to your local clinical genetic service would be the best way. So Emma's currently in Leeds, so she works for the Yorkshire Genetics Service. So you'd probably be able to get referred to Emma's service that way. So yeah, go through the GP, that's probably best.
Thank you. I think we have another question here.
So why, if I get genetic testing done, why can't you keep my data on file? So if you have additional breakthroughs, I suppose, in the future, you could contact me because you now know what it means.
So excellent question. So first and foremost, most people who have a genetic test, their DNA and the data from the test will be stored. And so that's something you should be aware of through the consent process and the recorded discussion that's filled in when you have a genetic test. So the DNA should be there. It's stored indefinitely. However, whenever a new genetic test is needed, a patient needs to re-consent for that. And I think there are a handful of genetic services around the country who have registers of patients with different conditions who will actively go back to their patients and say a new genetic test is available now. But for most genetic services, we are incredibly busy and understaffed. And for lots of us, it's just not possible for us to go back to patients. So that's why, as Tim said, we'll often say in our consultations, please come back to us. So whether it be that we've found a genetic change that's causative and it's sort of case closed in some ways, still come back to us to talk about reproduction options or things in future. Or if we haven't found a gene change or it's a variant of uncertain significance, please come back to us. It's much easier for you to remember to come back to us than it is for us to contact you. The only exception to that, at least in Leeds, is that if we find a variant of uncertain significance that then is upgraded, then the lab will typically automatically issue a new report to every patient that was found to have that variant of uncertain significance. So say if we found a VUS 10 years ago, we've found that exact same gene change in a different family in a different part of the country, there's new evidence, it's been upgraded to likely pathogenic, that should trigger a new report from the local lab to everyone that was found to have that variant of uncertain significance, and that should trigger a letter from clinical genetics saying, we've had an update, we need to speak to you again, please get referred back to us via your GP. Does that answer your question, sorry?
Just to say also, because we're screening relatives in terms of checking other people's hearts to see, to monitor if their heart's going to develop it, they're all being followed up, including children as well. So someone in the family will be assessed frequently assessed at that time. So there'll be an option for us to then talk to that person to say, oh, actually, please go back to your family members and say, we've got a new test, etc.
Thank you. Do we have any other questions?
There's one here, Steph.
Thank you. Thank you. So like IVF, that could come with complications, either multiple births, twins, etc., or just pregnancies that don't come to fruition. Do you get the same risks with this? I can't think the initials, the IVF type.
PGT.
Yeah. Does that come with the same risks?
So before I ask what risks, would they only ever implant one embryo at a time? Because this is PGT, it's not IVF. IVF, often people go through IVF when they're struggling to just fall pregnant. It's not about a genetic condition. So with PGT, they will only implant an embryo at a time because they've done all this work. They want to help you have a healthy child. So one embryo at a time. If that embryo decides to split and be twins, well, there's that. In terms of risk, are you thinking of like the little embryo then developing the condition later on?
No. Sometimes sort of, they have miscarriage and things that the pregnancy.
Fine. So once you have had an embryo implanted, the risks for any other pregnancy are the same. So if it miscarries, if it develops something else, because they only test the embryo for one thing, you would still have the normal risks for any chromosomal problems. So thinking about, something like Down syndrome, etc. What I will add is there is a misdiagnosis risk. So with PGT, which is why some people who have PGT will ask for genetic testing to confirm at birth. We won't do it during a pregnancy, but some centres, and that's important to ask. So for anyone going through PGT at the moment, ask your centre, what is your misdiagnosis risk? And that is just that they have tested the embryo. They've said it's negative, but actually it's positive. But it is slim, very slim. They wouldn't offer it if it was more than that. So, yeah.
Thank you. Do we have any questions?
If a child was born to a couple and one of the parents had cardiomyopathy, would the child be tested at birth?
Do you want to go?
So this is a contentious issue. One that is talked about by genetic services over and over and over again, and I think practice is different in different places. So I'll speak on behalf of Leeds, who perhaps are more traditional in their approach to this. So cardiomyopathies are often, but not always, an adult onset condition. And our policy is that we don't test children for an adult onset condition for lots and lots of reasons, including the child's autonomy and protecting their right to choose to have that test when they're older, because genetic testing has lots of implications. And ideally, wherever possible, we want that child to get to an age where they can be part of that discussion, understand the lifelong implications of genetic testing, and still choose to have it. Where there is any clinical risk at all, so where there's a person in the family who's been diagnosed in childhood, then yes, we will absolutely do the testing in childhood, sometimes from birth. But it does vary from centre to centre. I think we're trying to align on it. I think the new BSc guidelines encourage people to be more flexible around testing in childhood, but it's a controversial subject. And, personally for me, I try and take a person-by-person approach. But you will find slightly different practice in different centres around the country.
Mm-hmm. So I'll answer from the Brompton point of view. So absolutely agree with everything that Emma has said. It is a tailored approach. It's person by person. However, we do test children quite often. And the reason for that is because there is evidence to show that if a child is aware of what they have, the younger, they can then grow up knowing this, as opposed to having a new decision about genetic information and having to cope with that as an adult, or someone who's already wanting to be a footballer, or someone who wants to be an RAF pilot, etc. So it really is, it depends. We offer screening for children from birth for some cardiomyopathy conditions. So to try and help that child understand why they're going to hospital every year, sometimes we can do a genetic test and they might not have to come at all. So, but it is a tailored approach, and there are one or two genes which are certainly adult onset for the most part, and so we do not test children for those.
I've got 3 children, and
I don't think we can hear you, Steph.
Oh, you can't.
Oh, there we go.
I've got 3 children, and they are all negative for the gene that I have.
Lovely.
And I was the gene was identified when my first son was about 7. And that was the disease-causing gene. It's a troponin mutation. So when I had my 18-year-old and 20-year-old, they were actually tested at birth. Okay. And that wasn't to help them. That was to help me. Mm. And luckily, they were negative. Mm. But what if they'd been positive? Mm. I'd have been an anxious, nervous wreck. Mm. But thankfully, I have a happy story. So it's been very interesting. I've learnt a lot, and I hope you have all learnt something. If you have any further questions, do grab one of us and we'll be happy to help. Also to say there's some leaflets at the back about genetics in pregnancy and about genetics in cardiomyopathy. We also have the cardiac nurses available on the phone Monday to Friday. So use them for some information if you need to as well. Thank you very much. That was very good.